I'm hoping you're back. It's a bit hard to know. So I hope you've enjoyed this morning. I think there's been some really great sessions. I'm Victoria Cornelius, so I'm going to be chairing this final session of the morning. And in it, we're going to be hearing more about the ICH E9 framework with some practical examples. And we're also going to be hearing about some experiences of people who've been using it. So we've got 3 excellent talks coming up. 2 are from Susie. And also we've got our final talk coming up from Chrissy Fletcher on who's from JSK. So just to remind you, if you want to put in a question, please use the Q&A function, and we can do that as we go, and then we can look at the questions at the end of each of the talks. So for now, I just want to introduce my colleague, Dr. Susie Crowe, for the first talk. So she's head of our trial methodology at ICTU, and she's currently undertaking an NIHR advanced fellowship where she's developing methods for accounting for post-randomization events. So I think it's fair to say she's been living and breathing this Estimand framework for the last couple of years and is perfectly placed to give us an introduction to more detail. So thank you, Susie.
Thank you, Victoria. So I'm now going to give you an overview of the ICH E9R1 addendum, which introduced the Estimand framework as a sequential process to follow when designing a new trial. This to ensure that trials really do address the clinical questions of interest. So to do so, we're going to consider designing a new trial in severe chronic eczema. So we're going to work through the framework for this trial, and I'll cover some general considerations that surround the choice of strategy for handling into current events. Then I'll go through the impact on trial design, conduct, and analysis. And I'll finish with some real-life applications of the Estimand framework. This will include a COVID vaccine trial and a surgical trial. Now, some of my slides do include adapted training material that are freely available by ICH. So this presentation comes with the standard acknowledgement that the views expressed within shouldn't be understood or quoted as being made on behalf of ICH. Okay, so to bring the framework to life and to show you how it helps to ensure trials address the question of interest, I'd like you to suppose that we're planning a trial to test a new biological treatment against placebo in severe chronic eczema. So eczema is a debilitating skin disease characterised by red itchy rashes, which can severely affect quality of life. Now, the primary objective of this trial is to compare a 12-week course of a new biologic against placebo in routine practice. Now, the primary endpoint is to be the severity of eczema at 12 weeks, and this will be assessed by the Eczema Area and Severity Index. So that's the EASI for short. So this is a core outcome that's used in studies of eczema. Now, rescue medication in the form of oral steroids, such as prednisolone, are to be available to participants if needed. So this is ethically required, as such rescue therapies are also available in routine practice. So what exactly do we want the trial to find out? Well, if we specify the treatment difference between the biologic and placebo on eczema severity at week 12, this might initially sound okay, but I hope this morning's talks have opened your eyes to how there's in fact quite a lot of ambiguity here. So this doesn't provide us with enough information to inform exactly how the trial should be designed or analysed. Now, some patients will take rescue treatment whilst others won't, and this will affect the interpretation of their outcomes. And it's also likely that some participants will discontinue their assigned treatment early. This might be due to lack of efficacy or because of a side effect or some other reason. But this will also affect the interpretation of patient outcomes. So together, the rescue medication and the use of treatment and treatment discontinuation can create quite a lot of ambiguity on what we could find out here. So we could ignore both of these events and look at the treatment effect regardless of the use of rescue or any treatment discontinuation. Or we could alternatively design a trial to estimate the treatment effect for only those that would always adhere to treatment and not use rescue medication, or something entirely different. There's many different possibilities here. The point is that because of these events, lots of different treatment effects could be considered, and they could give us quite different answers. So if we're not clear on exactly what we want at the start of the trial, we might not end up finding out the answer to what's most important. And so this is where the ICH E9 addendum comes in. So the addendum on Estimand and sensitivity analysis in clinical trials. So it was born following recognition that the treatment effect is not always precisely defined, which has largely been down to a lack of transparency as to how to handle into current events, such as treatment discontinuation or other medications use. Now, historically, the data collection and analysis method would inform which treatment effect is being estimated in a trial. But the addendum reflects a shift in the view towards how now rather exactly what you want to find out, which is the estimand of interest, should inform the data collection and your analysis approach. So by following the Estimand framework that's set out in the addendum, we can design our trials so that they address both useful and clear questions. So the addendum has been around for just over 2 years now and is adopted by medicine regulators worldwide. Now, its focus is on confirmatory trials and on clarity of treatment effects that are of interest to regulatory decision makers. But I'd like to highlight today that it's applicable whenever treatment effects are to be estimated. So it's relevant in all phases of clinical development. It's useful in clinical trials and observational studies, regardless of the therapeutic area or experimental context. But today we are focusing on the clinical trial setting where we're interested in treatment comparisons. And although it's an extension to ICH-E9 statistical principles, it's far-reaching and not just for statisticians. So I'll now talk you through the Estimand framework whilst applying this to the eczema trial to show you what it's all about and how we can use this to design the eczema trial so that it answers the question of interest. So the Estimand framework is a sequential process to follow, and it starts right at the initial planning stages for a trial, when clear general trial objectives should be translated into estimands. So as you've already heard this morning, an estimand is just a precise description of exactly what question you want the trial to find out the answer to. When you're first getting familiar with estimands, remembering what they're all about, like Amanda, I like to think it can be helpful to think of an estimand as exactly what you demand to know from the trial because of that nice rhyme. But the estimand, it really is just an extension of the objective thought through with additional details. So there's no ambiguity on what the trial is investigating. So it's the star of the framework. As everything subsequently then should revolve around this, so that the trial does find out exactly what you want to know. So after defining the estimand, the study design and conduct can then be thought through and proceed. And it can proceed in the way that's appropriate for the estimand. And then an appropriate statistical analysis can be selected. And this is what the addendum calls the main estimator. So this is the machinery that gets you what you demand to know. So for example, this might be a linear regression model or any other relevant statistical method of analysis. And then when you have the data, this will provide you with the numerical result that you're actually interested in, which is what the addendum calls the main estimate. So this is the answer to what you wanted to know. So for example, in our eczema trial, it might turn out that we get a result of a mean treatment group difference in easy points of 7. Now, what I hope this figure reinforces here is that the method of statistical analysis is quite separate to the estimand. So the estimand is what you want to know, and it must be thought through first. And it describes in words what the numerical result you get at the end will represent. Whilst the statistical analysis is how you'll get there, and it should come after establishing what you want to know, so that it really does get you to where you want to go. Now, just to help distinguish the estimand, the what we want to know, from the analysis methods and demonstrate why the estimand must come first, I'd like you to, for a moment, now think about baking a birthday cake for your hedgehog-loving friend. And when baking a cake, you naturally first need to know exactly what cake you want to bake, like this lovely-looking hedgehog cake. Now, only then can you go and buy the right ingredients and find the right recipe so that you end up making the cake that you want. Now, if you're anything like me, the cake never looks like the picture, but nonetheless, you'll end up with a hedgehog cake that's as close as possible to what you wanted, that your friend will love because they love anything vaguely hedgehoggy. Now, just like this in trials, it's important researchers have a clear understanding of what the goal is to find out. So that's the estimand. So that's our desired cake that we want. Only then can we determine a suitable trial design so that we obtain the required data and select the appropriate statistical method of estimation. So that's the appropriate estimator, which is our recipe. And then we'll use this to obtain the desired numerical result that we're after. So that's our best estimate of the treatment effect that we're interested in all along. Otherwise, if we're not clear on this and we're not clear on what we want, you might not collect all the data you need, or you might not use an appropriate method of statistical analysis that gives you what you want. And you could end up estimating something entirely different to what you wanted to know. Just like if you don't know what you're baking and were to throw the only things you had in your cupboard into a bowl and you don't use the right recipe, you'll end up with a mess of a cake just like this that nobody will want to eat. Now, you might have seen this hedgehog cake before. As full disclosure, I didn't come up with this fantastic analogy. My acknowledgements go to Simon Grund, who was happy for me to share this with you today. But I think it's a great way of remembering the estimand, the estimator, and the estimate, all the E's. But now going back to the framework, a key point the addendum highlights is how it's important to always proceed sequentially through this from the top to the bottom. So the trial objective should determine the estimand, and then the estimand informs the design, conduct, and statistical analysis. This so that the numerical result you get as output, the estimate, really does represent what you wanted to know. But when establishing the estimand, it's also important to think through and assess that a reliable statistical method exists to give you a reliable estimate of what you wanted to know. So this is a key aspect for trial statisticians to evaluate. Now, where issues exist to derive a reliable estimate for a particular estimand, for example, if it's not anticipated that you'll actually be able to collect the data that you need for a particular estimand, then the trial objectives would need to be reconsidered from top down, following the green arrows. Now, importantly, you should never go backwards and pick a statistical method which determines what's being found out, hence what's being achieved. So the specification of the primary estimand is the critical start aspect for any trial. And so this has been introduced in the earlier talks. So we know there are 5 attributes of the estimand that were clarified in the addendum. So we need to specify these when designing a trial, such as the eczema trial. Now, a key point I'd like to now emphasize here that the addendum draws out is how interrelated these attributes are. So which you'll see this for the eczema trial. So intercurrent events might be incorporated into the treatment conditions, the population, and or the variable attributes, or they might be clarified separately. For example, the treatment conditions, these are the treatment strategies you want to compare. So these might be just intervention A versus intervention B, as you've got them in your protocol, but it's not necessarily what's in the treatment section of your protocol. The treatment condition might incorporate an intercurrent event, such as rescue medication, and so therefore it might be specified as intervention A plus rescue medication versus intervention B plus rescue medication. Or it might also incorporate how treatment discontinuation is handled. So the addendum does raise how precise clarification of the treatment condition usually would involve clarifying how we're going to handle treatment discontinuation or use of other important medications. This just so it's immediately clear exactly what's being compared. Now, the population is the wider population of potential patients who you want to know the treatment effect for. So it's not just a group of patients recruited into the trial, and it's not the analysis population. So this distinction is important to be aware of. Now, the population will most often be defined by the group who are defined by the study's inclusion and exclusion criteria, as written in your protocol. But this isn't necessarily always the case. So in some cases, a subgroup might be of interest, and this might be either further defined by a baseline characteristic, or it might be defined in terms of a potential intercurrent event. So that is, it could be the subgroup of those who would never experience an intercurrent event, irrespective of what treatment group they're assigned to. So for example, the set of patients who would always tolerate and remain on treatment, regardless of their randomized arm. So this is the case when the principal stratum strategy is used, which we'll come back to shortly when we take a closer look at this. And then the outcome variable or endpoint, this is what's measured for each patient. And so it might also include whether the patient experienced an intercurrent event. Now, this will be the case if a composite strategy is used. So if here, for example, the outcome might be a poor clinical outcome, or if rescue medication was required. Or if a while on treatment strategy is used, then this will redefine the time point of measurement. So we will again come back to these 2 strategies shortly. But for now, let's look at the estimand for our eczema trial. So what treatment conditions do we want to compare? Well, our primary objective is to compare a 12-week course of the new biologic against placebo in routine practice. And we also know that patients will be able to use rescue medication in the trial, and some might also stop treatment early. So we must include these 2 intercurrent events somewhere in the estimand, as they will affect the interpretation of patient outcomes. Now, we will incorporate these in the treatment condition as suggested by the addendum, as these 2 events are just intrinsically related to the treatment comparison. Now, the in-routine practice factor here is key to inform what we want to compare. So we are aware that the rescue medications are also available in routine practice. and how in clinical practice, there will similarly always be patients who will stop taking treatment for various reasons. Therefore, to align with the objective, we should include and allow for these in the trial treatment effect. So we can specify the treatment condition precisely as 12 weeks of treatment with the new biologic compared to placebo, which are both taken at a dose of 150 milligrams every other week, regardless of any treatment discontinuation or use of rescue medication. Now, so what about the population? Well, for our eczema trial, as the objective is to assess whether the new biologic improves disease severity in routine practice, this aligns with us wanting to know the treatment effect for all those who would be eligible to receive the treatment in routine practice. So the corresponding targeted population would be all patients with a confirmed diagnosis of severe chronic eczema who meet the trial eligibility criteria. So we don't want to restrict this in any way by an intercurrent event status or a baseline characteristic. Now, next we have the variable or the outcome to be collected for each patient. And this we know is the change in the eczema severity score at week 12 as measured by the EASI score. So we can add that into our Estimand description. Then the summary measure. So this is how outcomes between different treatment conditions will be compared. For example, this might be a difference in means or a risk ratio, etc. So here for the eczema study, we've got a continuous outcome variable. So we can clarify that we'll be interested in the mean difference in our outcome. So that's the mean difference in the week 12 change in EASI between the two treatment conditions. So I've added that in here. Then we need to think about how to account for intercurrent events that are post-randomization events that affect the interpretation of the patient outcomes. And so ones that are not yet reflected in the treatment, population, or variable elements. Now, the intercurrent events to consider will depend on the specific therapeutic setting and trial objective. Now, you've already heard some examples being discussed this morning. And for the eczema trial, we have already included rescue medication and treatment discontinuation as part of the treatment attribute. So we've already said that we're interested in the treatment effect regardless of these two events. So these have been handled using the treatment policy strategy. So if we hadn't already done this, it would be important to think about these and clarify them now. But I'd like us to suppose we do have one more intercurrent event in this trial to plan for. So this will be use of other topical therapies. So this refers to the use of any treatment that can be applied to the skin for relief of eczema symptoms, including any creams or emollients that are also readily available to patients in clinical practice. So their use will impact the interpretation of patient outcomes. So we now need to clarify what we want to know with respect to this event and consider which strategy we're going to use to handle this that fits our trial objective. So I'm now just going to outline how each of the 5 strategies for handling intercurrent events that Brennan and Tinsar have introduced earlier would handle topical therapies, whilst covering a few further general considerations surrounding each that the addendum raises. So these might be important to bear in mind, which will help inform the choice of strategy for topical therapies. Well, following this, I will ask you which strategy you think would be most appropriate for the trial objective using a Zoom poll. So keep that in mind, as I'm going to ask you soon which one you think is most appropriate. Okay, so the first option is the treatment policy strategy, which is the strategy which involves considering the effect of the intervention regardless or despite an intercurrent event's occurrence. So here, the event really is considered part of the treatment under evaluation. And so this is the strategy where, with regards to the treatment effect, we're essentially unconcerned or we're indifferent to the occurrence of the intercurrent events. So you could say we are meh about the events. So if we applied this strategy to the topical therapies in the eczema trial, this would consider the treatment effect despite the use of topical therapies. So this strategy doesn't do anything differently and continues to use patient outcomes after use of topical therapies. Now, in general, when a trial objective is to assess how a particular treatment performs in routine practice, such a strategy can be quite useful to handle intercurrent events that occur in the trial and that would also occur in routine clinical practice. Now, on the other hand, if an intercurrent event would occur in a trial but not in routine practice, then this wouldn't be so relevant where your objective is to assess how the treatment performs in routine practice. Now, another general point to note for this strategy is that by definition, generally, it cannot be used to handle terminal events such as death, where values for the variable after these terminal intercurrent events don't exist. As for example, in a trial where you're measuring quality of life, you can't say you're going to use patient values of quality of life regardless of whether they died or not, as it's impossible to measure quality of life after death. So you'd need to use one of the other 4 strategies that do something differently about the intercurrent event's occurrence. So the second option is the hypothetical strategy. So this one seeks to look beyond what was observed, and it targets the treatment effect in a hypothetical scenario. So applied to the topical therapies in the eczema trial, this could consider the treatment effect if topical therapies were not available. So the if is a small but critical word here. So here we're doing something differently because of the intercurrent event's occurrence. And although some patients will have experienced using topical therapies, we essentially imagine this didn't happen for all the patients, and we want to know how the treatment performed in that imaginary scenario. So because of this, implicit or explicit predictions or imputations may be required for the patients who experience the intercurrent event, as their desired outcomes not actually observed. So there will be additional assumptions required to actually estimate this Estimand. Now, in some cases, it could be quite valuable to implement a hypothetical strategy. So for example, in studies with certain treatments that are available as rescue medication that are not available in routine practice. This would be useful when your objective is to explore how the treatment performs in routine practice. In that scenario, you'd want to consider what was the treatment effect if rescue medication was unavailable. But in other scenarios, as also touched on by Thinzar, some hypothetical scenarios might be less clinically plausible. For example, the addendum specifically points out how it's quite questionable to want to know the treatment effect if all patients could tolerate treatment despite toxicities, as this would essentially involve looking at the treatment effect if patients continue to take treatment despite any adverse events. I think the clinical interest of such hypotheticals is likely limited, as this scenario wouldn't ever really occur in practice. Now, on the other hand, for handling treatment discontinuation for logistical reasons, the hypothetical strategy might be more reasonable. That's why it might sometimes be necessary to separate out treatment discontinuation for reasons related to treatment versus withdrawal not related to treatment. This so that the 2 different types of treatment discontinuation can be handled differently. Now, in the eczema trial, we are handling both types of treatment non-adherence in the same way, so as part of the treatment, so we haven't separated this out. But generally, overall, if you're considering a hypothetical strategy, it's important to be careful to make sure that the hypothetical scenario is plausible and will provide meaningful information for your objective. So the description of the strategy should contain the details of exactly what's hypothesized to occur or not occur, so there's no confusion. So the third option is to use a composite strategy, which is where the outcome variable is reconstructed so that the intercurrent event is a component of the variable. Now, in the most simple scenario, a binary variable could be defined as a responder or a non-responder variable based on a clinical measure. So in the eczema study, the third option that we could use would be to define a composite outcome of no topical therapy and a favourable clinical outcome, such as EASI-75, which means the patients had a 75% improvement in the EASI score from baseline. Now, considering use of topical therapy as a failure here, but this does fundamentally change the question we're asking. Now, generally, composite outcomes don't have to be binary. An ordinal variable or a categorical composite could also be formed. And it is also possible to retain a numerical outcome, and a particular value could be assigned to those experiencing an intercurrent event. For example, if you've got a trial where your outcome's quality of life, but perhaps death's an intercurrent event, one could ascribe anyone who dies a quality of life a score of 0, but this does require careful thought as to what value would be clinically justified, which can be quite tricky, as really in this scenario, perhaps death should be ascribed a value that's worse than 0. And then also challenging questions do arise around the estimation of effect sizes when such an approach is taken. So although it is possible, it might not always be the best approach to use a numerical composite. Now, an alternative composite strategy consists of employing ranking methods. So here you can assign ranks to outcomes based on their clinical outcomes, whilst giving patients who experience intercurrent events worse ranks, and then you can analyse the ranks. Now, generally, as with any composite outcome, complications might arise if treatment has a different effect on the components. So this is just important to be aware of if going down the composite strategy route. And then the fourth option is the while on treatment strategy, which considers the response to treatment only prior to the occurrence of the intercurrent event. So this strategy would consider the response to the placebo or biologic at 12 weeks or at the last known time point prior to initiation of topical therapies. So it redefines the time point in the outcome variable. So as this impacts the time element of the variable, generally this strategy is appropriate only when the duration of treatment is not important, either because duration is truly not important or because the rate of an event or outcome is constant. Now, although the name does refer to treatment adherence, the strategy can be applied to a variety of other intercurrent events, such as looking at responses to treatment prior to death, where, as you've already heard today, this is referred to as while alive. So the final fifth strategy is the principal stratum strategy. So this handles events by restricting attention to wanting to know the treatment effect for the principal strata. Really, that's just a subgroup of the population of interest whose intercurrent event status would be identical irrespective of their treatment group. So this could be used to consider the treatment effect for patients who would never use topical treatments, regardless of their randomized arm. So this is subtly different to wanting to know the treatment effect for only those in the trial who didn't experience the event. This strategy seeks to estimate the treatment effect for the set of all individuals who would never experience the event, regardless of what arm they're allocated to. So this is to avoid any confounding by treatment received, because the key property of principal strata is that they're not affected by treatment assignment. And this means that the resulting treatment effect has a causal interpretation. But either strong assumptions or modelling or particular trial designs will be required to establish the principal stratum. So this is the strategy that impacts the population attribute. So because of this, you do need to carefully think about how helpful it is to know the treatment effect for only the subset of patients who would not use topical therapies, because the results will no longer apply to the entire trial population. In clinical practice before treatment initiation, you'll probably not be able to identify the patients who would not have the intercurrent event status, so it might not always be so useful for treatment decisions, but it still can provide valuable information on how the treatment would perform for someone who would not have a particular event. Okay, so there are the 5 different ways we could handle topical therapies in this trial. So via a Zoom poll, I'd now like to ask you what strategy you think is most appropriate and aligns with our primary objective of wanting to know how the treatment would perform against placebo in routine practice. So recall the topical therapies are just any emollient or cream applied to the skin that are readily available to patients from pharmacies. So I'd just like you to have a go and select which of the strategies you think most aligns with our objective. So we've got the 5 different options of the strategies, and you might not be sure, and that's okay. Feel free to have a guess. I'll just give you perhaps 20 seconds to have a think and fill in your answer. So I can see we've got a lot of responses coming in, so just give you 10 more seconds. Brilliant. So I'm going to close the poll here now. So maybe have a really quick think if you haven't done it yet and you still want to. Now I'll share the results with you. So we can see majority here, 61% have gone for treatment policy. We've got 5% going for hypothetical, 23% have gone for composite, 6% for while on treatment, and 5% principal stratification. So we have got quite a bit of variability here, but the majority going for treatment policy. So what do we say here? So as topical therapies are available in routine practice, it's the treatment policy strategy approach that would be most relevant to apply here. And so to consider the treatment effect, regardless of its use, as our objective is to assess treatment benefit in routine practice. I mean, obviously, this is just a simple example, and in real life, you would talk to the clinician to confirm that's the right thing. We've gone for treatment policy here as this best aligns with our primary objective, so which corresponds with the majority. So with clarification of how these 3 intercurrent events are now handled, this completes the specification of the primary Estimand for the eczema trial. Although we have used the treatment policy strategy for all 3 intercurrent events here, I want to point out how it's not necessary to use the same strategy to address all intercurrent events. It just so happens that that's what's most relevant here. Okay, so suppose in our eczema trial, whilst we're designing it, we anticipate that there'll also be about 15% of patients lost to follow-up at 12 weeks. Now, the addendum makes it clear that missing data are not actually intercurrent events. So rather, missing data are defined as data that would be meaningful for the analysis of a given estimand, but that were not collected. So they should be distinguished from data that do not exist or data that are not considered meaningful because of an intercurrent event. The missing data as such then are not considered relevant in the construction of the estimand, which is why we haven't touched on this yet. So rather, the handling of missing data should be addressed in the statistical methods under the how, not under the what. So for this reason, in any trial like the eczema trial, it's important that in trial design, we plan to collect informative reasons for why data are missing so that we can distinguish the occurrence of the intercurrent events from the missing data. For example, loss to follow-up might actually be better recorded as treatment discontinuation due to lack of efficacy in some cases. Now, where treatment withdrawal has been identified for a patient who's got missing data, then they can actually be handled through the strategy chosen to account for that intercurrent event, and not as a general missing data problem. Now, other standard aspects of trial design can then follow and align with the estimand, so that we then get the data that we need to address the estimand of interest. So alignment with the estimand should be sought when considering the type of trial. So our eczema trial is a double-blind, placebo-controlled parallel design. So this will be appropriate for our comparison. But other types of estimands might require specific trial designs. So for example, an enrichment design with a run-in period could be useful if you want to identify treatment adherers prior to randomization. So that could be a really good trial design to use if you are opting for a principal stratum strategy. But also, the estimand alignment needs to be made for the duration of subject participation. This should be appropriate, which we know we want for 12 weeks, as should discontinuation criteria for individual subjects, subject withdrawal criteria. So in an eczema study, we want to maximise data collection for the 12 weeks. So we know medications permitted before and during the trial, which we know will include the rescue medication and the topical therapies here. And as well as that, alignment with the estimand should be sought for the procedures for monitoring subject compliance, because we want to record that accurately. And we also want to ensure alignment with specification and measurement of our efficacy parameters. So these all need to align with the estimand. Now, the precise description of the primary estimand of interest should also inform sample size calculation. Now, when calculating sample size, we typically use estimated effect sizes and variability from past studies. So when referencing historical studies, it's important to take into account that these might have reported estimated treatment effects or variability estimates based on a different estimand. Now, as discussed in the addendum and in the Delta 2 guidance on choosing the target difference, it's the impact of the strategy to reflect the intercurrent events. This should be included in the effect size that's targeted and the expected variance. So for the eczema trial, the sample size should be based on variability as estimated in a previous trial that would also use a treatment policy approach for handling rescue medication, topical therapies, and treatment discontinuation. And we should power the study for the effect size that we expect to see, given some patients will take rescue medications and some will not. Now, the estimand of interest will also inform the data that needs to be collected during the trial. So for our eczema trial, we will need to collect data post-treatment non-adherence and after rescue or any other topical therapies. So this is because an estimand based on the treatment policy strategy does require participant data to be collected both before and after the occurrence of the intercurrent event. Now, different estimands will have different requirements regarding data collection. So a composite strategy, or a while on treatment, or a principal stratum strategy would not require data collection after the intercurrent event. And for a hypothetical strategy, data after intercurrent event is irrelevant. Now, what I haven't brought in yet, but we'll come to shortly, is how a trial might have more than one estimand of interest for that primary outcome. Now, in general, the data collection should be appropriate to address all the trial estimands that are going to be looked at. So it might, if you actually don't have a treatment policy as your primary outcome, primary estimand, but you have it as a supplementary, then you need to make sure your data collection is still appropriate. So in that supplementary analysis, you can look at your treatment policy. Now next, the analysis approach, or as the addendum refers to as the estimator, this can be chosen to align with the Estimand. So this will then mean that the trial will result in an estimate of the desired Estimand. So this is our recipe, selecting that which will take us from what we want to know to the numerical result. So the estimator selected should be able to provide an estimate on which reliable interpretation can be based. So for the eczema trial, we know we're going to use a linear mixed model for repeated measures, and we'll fit this to all observed data, including the data of those rescued or otherwise. Now, when thinking about reliability and selecting statistical methods, it's important to consider the number and plausibility of assumptions that need to be made in the main analysis, including those associated with the use of modelling to address missing data, or for example, to replace observed data, if this is required for estimating in the hypothetical strategy. Now, there's no black and white definition of what qualifies as reliable here. This is something for trial statisticians to think carefully through in each setting, but this is the same as what we have always done when writing statistical analysis plans. Now, of course, methods of statistical analysis will typically be underpinned by certain assumptions. So in the eczema trial, a mixed model will assume any missing data is missing at random. So that is, unobserved patient data will be similar to that of the observed patients in their treatment arm with similar characteristics. Now, the addendum states how sensitivity analysis should be conducted to assess the robustness of results to the underlying assumptions. And the addendum specifically defines sensitivity analysis as a series of analyses conducted with the intent to explore the robustness of inferences from the main estimator to deviations from its underlying modelling assumptions and limitations in the data. As such, sensitivity analysis is defined as analysis that continues to address the same question of interest as the primary analysis, so which you can see here. So the sensitivity analysis is analysis which remains aligned with the estimand of interest. Now, you may have more than two sensitivity estimates, but that's what I've just shown in this figure here. Now, as analysis can often involve more than one assumption, the addendum does recommend investigating the impact of changing only one assumption at a time in sensitivity analysis, and how particular attention should be given to missing data in sensitivity analysis, as we'll plan to do for the eczema trial. And with non-negligible missing data, the impact of varying the missing data assumption in ways that remains consistent with the estimand of interest should be investigated. So the estimand of interest will define what data is missing, and it will also prescribe how missing data should be handled in the analysis and the sensitivity analysis. Now, sensitivity analysis is different to other planned analysis, which answers a different question. So that would include analysis which refers to a different estimand to more fully investigate and understand the trial data. So the addendum refers to such analysis as supplementary analysis. So that's formally defined as a general description for analyses that are conducted in addition to the main and sensitivity analysis, with the intent to provide additional insights into the understanding of the treatment effect. So for example, for the eczema trial, suppose an additional objective to more fully understand the treatment effect is whether a 12-week course of the biologic would improve disease severity for all patients if rescue was not available, but otherwise is used in routine practice. So as this is a different question, this is not addressed by a sensitivity analysis. So this is a supplementary analysis. So the estimand that aligns with this objective does have some overlap with the primary, but with some key differences that I've highlighted in purple here. So we now want to know the effect of 12 weeks of treatment with the new biologic compared to placebo, despite any treatment discontinuation if rescue medication was not available. So we can clarify here that our interest lies in using a hypothetical strategy to handle rescue medication. Now, use of topical treatments or the treatment discontinuation can remain handled as a treatment policy strategy here, as otherwise we want to know how the treatment performs in routine practice. So that completes a walkthrough of the key elements of the Estimand framework applied to the eczema study now. Now, I'd now like to show you some further examples of estimands that have been used in practice. Now, you may not have noticed as estimands didn't make it into the main trial publications of results, but estimands were used in the protocols of the 3 biggest COVID vaccine trials. So this included this one run by Moderna, which you can find in its protocol in its supplementary material alongside its main publication in the New England Journal of Medicine. So in this trial, the objective was to demonstrate the efficacy of their mRNA vaccine to prevent COVID. So let's look at their chosen aligning Estimand. So the general description of the primary Estimand provided in the protocol that I've simply copied here was that vaccine efficacy will be measured using 1 - hazard ratio for their mRNA vaccine relative to placebo of COVID-19 from 14 days after the second dose of the IP in adults. And they're going to use a while alive strategy for deaths unrelated to COVID and a treatment policy strategy for early infection. And a principal stratum strategy would be used to exclude participants missing a dose of IP or being COVID positive at baseline. And then they also break this down attribute by attribute. So their population was adults aged 18 years or older in circumstances at high risk of COVID infection, but without severe risk of having disease from other medical conditions. But they then did state that they excluded those who'd been previously infected or vaccinated with a medical condition or treatment that poses additional risks or COVID exposure pre-positive before. So this aligns to that principal stratum approach. The variable and endpoint was the time to COVID-19 disease, censoring at early discontinuation, early infection, or last assessment for an event not being observed, whichever one came earlier. Now, as you see here, their treatment conditions were specified quite simply as their mRNA vaccine as the test and placebo was the reference. And this is because all their intercurrent events, they just clarified those separately, which we'll get to after the population level summary. So this was specified as vaccine efficacy, defined as 1 - hazard ratio for the test vaccine versus placebo. And then here comes the intercurrent events. So this trial, they had 4 identified, and they've used different strategies to handle these. So the unrelated deaths were handled using while alive. So they only assessed outcomes up to the time of unrelated death. Early infections were ignored and patient data considered regardless. But missed doses of the vaccine were handled using the principal stratum strategy. So they were only interested in knowing the treatment effect for patients who would receive both doses of the IP. And being COVID positive at baseline was also handled using the principal stratum strategy. So they were only interested in knowing the treatment effect for the patients who were not COVID positive at baseline. So this example shows us how different strategies can be used to handle different intercurrent events, unlike the previous XML example. Now, for a quite different trial setting, we'll now look at the Estimand used in the fluid optimization and emergency laparotomy trial. So this is Floella. So Floella is a large pragmatic emergency bowel surgery trial that's currently in recruitment. So this trial is addressing the primary objective of establishing whether minimally invasive cardiac output monitoring to guide protocolized administration of intravenous fluid during and for up to 6 hours after major emergency bowel surgery leads to an increase in the number of days alive and out of hospital within 90 days of randomization. The general description of the primary Estimand presented in the SAP is as follows here. So this is that the Estimand for the primary outcome is the ratio of mean of days alive and out of hospital within 90 days of randomization between the protocolized cardiac output guided hemodynamic therapy arm versus usual care, which they've clarified, and then regardless of adherence or use of cardiac monitoring in the control arm. In participants aged 50 years or over who undergo emergency bowel surgery. And so this was then broken down into its 5 elements in a tabular form as follows here. So here we've got the population, variable, treatment, and population level summary measure. Now, given time, I'll just focus on how they handled the intercurrent events. So they'd identified 5 here. And so they'd handled surgery not being received using a principal stratum strategy. So they wanted to know the treatment effect only for those who would receive surgery. And then the other 4 intercurrent events, they've used a treatment policy strategy. So they want to know the treatment effect despite modifications after the surgery, or despite if they haven't received the cardiac output monitoring, or despite that they haven't initiated the cardiac output monitoring during the surgery, or whether they've used the actual algorithm that was intended. Now, hopefully these examples just help to bring the Estimand framework a bit to life and show you how others have formulated their Estimands. Because with clear specification of the Estimands, it's entirely transparent as to the exact treatment effect that they're addressing. So to sum up here, then the addendum we've seen introduces sequential framework and language to promote alignment between trial objectives, design, data collection, conduct, analysis and inference. So it all starts at the initial planning stages for a trial when the trial objectives should be transformed into estimands. So doing this does require careful consideration of intercurrent events and strategies as relevant for the clinical context. So subsequently, trial design, conduct and analysis can be aligned with the estimand. Now, importantly, missing data is not an intercurrent event, but it's rather an estimation issue. And sensitivity analysis should be conducted to explore the robustness of inferences from the main estimator to deviations from its underlying assumptions. And supplementary analysis are any other analyses that are conducted to fully investigate and understand the trial data, exploring alternative questions, thus that can include different estimands. So I appreciate there's quite a lot in this talk here. That was a whistle-stop tour of the guidelines for you so that you know what it's all about. But happy to take a few questions from the chat if any have come in.
Thank you so much, Susie. It's, like I said, a really great talk and really helpful to hear your explanations about, you know, the how different ways of approaching handling intercurrent events, and also just it feels like a tutorial we've been stepped through. So thank you. Do you want to stop sharing your slides and then we'll take a couple of questions? We haven't got very long and you've had lots of questions, and so I'm wondering if we can try something like a rapid fire question thing, because I've got sort of lined up 4 for you from 5 people. So I think first of all we'll take one from James, who was the first to post a question saying, look, designing a trial to produce the desired estimand sounds nice in theory, but how often is the scope for estimand specification limited by sort of practical or ethical considerations on how a trial can be designed?
Yeah, because obviously, like, I've just been working through specifying an estimand for a trial in opiate addiction, and it's sort of, we have had to sort of balance what's realistic with what's ideal, and you do have to make compromises. But with the estimand framework, it sort of just allows you to think through these in a sort of a consistent way, to sort of come to a conclusion that gives you what you want. And it might not be perfect, but life isn't perfect, but it enables you to sort of carefully think through things in the right form.
Thank you. I've lost one of them now. Okay, maybe somebody else asked it. There was one from Lee Middleton and Simon Bond, which were a similar theme, really. As some of you using the chat function, some are using the Q&A, so it's a bit hard to keep up. But it was basically about sort of coping with, so I'll ask Simon's question, Lee's is related. Do you consider the instant rate of intercurrent events when you're deciding how to proceed? As in, sometimes maybe, for example, death will be really rare because in a long-term condition, and then should you kind of do an interim and then actually have a bit more of a favour a simpler approach, as Simon puts it?
Yeah, that's a good question. And I think, yeah, the rates of intercurrent events when you're starting to design a trial, they will probably influence how you best see handling them. For example, if death's considered quite rare, in that scenario, it might be acceptable. I'm not saying this is the case in every scenario, but a hypothetical scenario might be more reasonable. But in other scenarios, you might want to do something else. If death is more common, you might want to go for that while alive approach. The bit about making a decision based on an interim analysis, that's quite interesting. And so I haven't actually seen or heard that being done. But I think, yeah, that's a really interesting proposal. So it'd be interesting to sort of see if that develops.
Okay, thank you, Susie. One from Kate Bennett, which I've had a thing about in the past, and I'm glad to see that you've come on with quite strong recommendations for the sample size, saying you should be including, basing the sample size calculation on the estimand. But Kate asks, how realistic is it going to know what the estimand is from other trials to be able to inform your sample size? So.
Yeah, I mean, that is a good point. I mean, I think we just have to sort of make pragmatic decisions here. Because looking back in past trials, as you'll see in my next presentation, sometimes it's impossible to unravel exactly what estimand they've used. So I think we just have to sort of be sensible and sort of obviously take a cross look at the literature and see what's available and discuss with clinical colleagues and just make pragmatic, sensible decisions.
Okay, thank you, Susie. I should probably stop the questions there. We can try and answer some of those, as we go along in the chat as well. Right, so you don't get much of a break, Susie, because you're now on to your second talk, but it's a much shorter talk. You're going to give us an introduction to how people are using it in the published literature. Is that right? And then ask us about some current practice. Thanks, Susie.
Yes, so I'm just switching my slides. Brilliant. So yeah, I'm in this presentation, I'm going to talk about the use of Estimands in the published literature. And then at the end, we'd like to hear again from you about your current practice and thoughts. So what I'm going to do is I'll present to you the results of 2 reviews that we've recently done investigating the use and the need for precisely describing the clinical question being addressed in trials. So that's the use of Estimands in the published literature. And so this includes a review of trial protocols that were published in October 2020, and then a review of trial results articles that were all published sometime in the year 2020. And then we'll use Zoom polls to survey your current practice and thoughts on using Estimands. Okay, so nearly 1 year after the final version and 3 years after the draft version of the ICH-E9 addendum was being published, how often can we actually understand the precise primary question a clinical trial is designed to address from its published protocol? So to explore this, Brennan Kahan, who you heard from earlier, led a review of protocols published that I was also involved in. So the results of this review are available open access already in trials, so do feel free to look these up for further information following today, because I'm just giving you a summary of the headlines. In this review, 50 trial protocols that were published in Trials or BMJ Open in October 2020 were reviewed. So for each protocol, we looked at whether the Estimand for the primary outcome was explicitly stated. Now, where an Estimand wasn't defined, we then assessed whether the Estimand could be worked out from the information that was presented on the statistical methods. So that's the estimator. Or as we considered earlier, so our recipe, whether from the recipe we could work out what was being targeted. Now, if from the methods we could unambiguously infer a single treatment effect that was being targeted, then we considered the Estimand as not stated but inferable. Otherwise, if it was not clear how to reconstruct the Estimand based on what was written in the protocol, for example, if the statistical methods section didn't state which patients or data points were to be included in the analysis, then we classed the Estimand as not inferable. So of the 50 published trial protocols reviewed, we did find that most of these had an academic or not-for-profit sponsor. So just to set the scene, so 92% of those. And it was found that none of these 50 protocols made any attempt to explicitly describe the primary question of interest. So none of them defined the primary Estimand. And concerningly, for 74% of the trials, the Estimand couldn't be inferred from the reported methods. So that is, the recipe or the statistical method didn't enable us to unambiguously tell what precise question the trial was going to address. This means that for most trials, it was impossible to understand precisely what clinical question the trial was designed to target from the trial protocol. I think it's quite concerning that in 3/4 of the trial protocols reviewed, exactly what question was being addressed couldn't be gathered. I think this shows us how using Estimands is necessary to enhance the clarity and improve trial design. Now, with Estimand specified, there's no room for any misinterpretation on the precise research question being addressed. And later down the line, we can also evaluate whether appropriate methods have been used. So what about the use of Estimands in published trial results articles? So how often can we actually tell precisely what questions trials have addressed from their final results reports? So what's the state of play here when it's critical to understand what questions have been addressed in order to make fully informed decisions about medical interventions? Now, as this is a new area of focus, also exactly what types of questions are trialists actually targeting? So to explore this, I've recently led a review of phase 2 to 4 randomized controlled trials that were published in 2020 in the 6 leading general medical journals. So for each article, similar to the protocol review, we assessed whether the Estimand for the primary outcome was explicitly stated, or whether the Estimand could be constructed and worked out from the information that was presented on the statistical methods. So again, whether we could work it out from the recipe. If from the methods we could ambiguously infer a single question or treatment effect that was being targeted, then the Estimand was not stated but inferable. Otherwise, if it wasn't clear how to reconstruct the Estimand based on what was written in the method in the article, then the Estimand was considered not inferable. Now, just to note, we did exclude certain types of trials from this review, including cluster crossover and non-inferiority and equivalence trials. This is because statistical issues can be quite different for these. But let's look at our results here. So in this review, we had a total of 255 trials that were identified and reviewed as eligible. Now, of these, 64% had an academic or not-for-profit sponsor, and 36% had a pharmaceutical or for-profit sponsor. So there was a good mix of sponsorships here. Now, overall, we found that none of the 255 articles completely stated the precise primary Estimand, but we did find that 4 attempted to define an Estimand, which was encouraging to see a small trickle of Estimands coming through. But unfortunately, these 4 missed 1 or more of the 5 aspects. So similar to the protocol review, most concerningly, for a large number of trials, we couldn't even infer the Estimand. So that was in 54% of trials, 1 or more of the Estimand attributes wasn't inferable. So we couldn't tell precisely what question the trial had actually addressed from the methods alone. Well, the main driver for this was the lack of clarity on the approach to handling intercurrent events, such as treatment discontinuation or rescue therapy. So we could only determine how intercurrent events were handled in 125, which was 49% of the trials. Now, of these, 4 stated the strategy, but for the majority, 121, we had to infer the strategy for handling intercurrent events from the statistical methods. Now, in the trials where the strategy for handling intercurrent events was stated or could be inferred from the methods, we found that 76% used a treatment policy strategy to handle the intercurrent events. But we also found examples of trials using statistical methods that answered hypothetical questions. So 14% used hypothetical strategies, and then 10% used composite strategies. So this was showing variability in the types of questions being addressed, such that you can't just assume a treatment policy strategy has been used in the absence of information. I think it's worth further highlighting that of these 17 trials that used a hypothetical strategy, only 2 stated that we were looking at the treatment, that they were actually looking at the treatment effect in a hypothetical scenario. So for 15, we had to use statistical knowledge to pick apart and unravel the hypothetical strategy from the statistical methods. So this did include some trials with treatment non-adherence due to adverse events, which employed an analysis method which actually estimated the treatment effect in that hypothetical setting as if participants continued treatment despite adverse events. And there were also some trials where patients died, which estimated the treatment effect in a hypothetical setting as if participants did not die. I think without Estimand, it's unclear whether the investigators were really interested in knowing these effects. Now, while these hypothetical strategies were inferable to statistical reviewers with statistical knowledge, I think we can't expect that all stakeholders will have the knowledge to decipher this. Therefore, inferability is likely to be a bit lower for non-statistical readers. Now, overall, what this means is that for most trials, it was impossible to understand precisely what primary question had been addressed in the trial. I think this is problematic as different reviewers of the trial, for example, such as policymakers, prescribers, or patients, might look at the results and assume different questions have been answered when this is not made clear. As we have seen, different answers to different questions can result in quite different impressions on treatment benefit. This could result in misinterpretation. So, for example, consider one trial that we found in type 2 diabetes that compared the mean treatment group difference in glycated hemoglobin for a once-weekly insulin regimen compared to a once-daily regimen. In this trial, when they asked what was the mean difference in the glycated hemoglobin for a once-weekly insulin regimen compared to a once-daily regimen, if all participants had hypothetically adhered to the treatment regimens and also not received the ancillary treatment, this gives a result of minus 0.18 percentage points. And we have a confidence interval of minus 0.38 to 0.02 and a p-value of 0.08. Whilst in the same trial, asking what was the mean difference in the glycated hemoglobin, regardless of the amount of randomized treatment or ancillary treatment. So this is the treatment policy effect. This gives the result of only minus 0.09 percentage points. So here the confidence interval is minus 0.29 to 0.20 with a p-value of 0.35. So you see here, we get a much more positive conclusion from the once weekly regimen from asking question 1. So the effect size is twice as big here. So to avoid misinterpretations, it's important that the question addressed be explicitly stated by including statement of the estimands. Okay, so that was the picture in published protocols a year after the addendum in October 2020 and in trials that were published in 2020. I think it really shows us why we need to use Estimands, because when they're not there, for a large proportion of trials, we can't even work out from the methods what treatment effects have been addressed. So at this point, we'd like to hear from you now via a few Zoom polls and find out your current practice and thoughts on using Estimands across your trials. So we're now at the point where it's about 2 years and 5 months after the publication of the addendum. So I'm just going to go into the polls. So I've got 4 questions to ask you here. So the first question we'd like to ask and get your thoughts on is, do you think we should be using Estimands when designing trials? So you can fill in yes, no, or unsure. So I'll just give you about 30 seconds to fill this one in. Got quite a lot of responses coming in, and we've still got about 15 seconds. Brilliant. So I'm going to stop sharing that with you now and show you the results. So overall, we can see that 92% of people said yes, we should be using Estimands. 1% said no. I hope we can change your mind in the next half an hour. And we've got 8% of people who are unsure. Brilliant. So that's question 1. Let's go to question 2. So the next question we'd like to ask you is, have you used Estimand in trial design yet? So the options here are yes, no, or it might be not applicable, because we know some of you are new to trials today. Just give you 30 seconds to have a go at answering this one. Great. And just a final 10 seconds if you haven't already filled this one in. Brilliant. So I'm going to close the poll now and show you the results. So we can see here that we've got 20% of people have used Estimand in trial design, which is great. We've got 73% said no, and then 77% is not applicable. So it's interesting that we've got a lot more support for Estimands, but we haven't all yet started using Estimands in trial design. So let me stop sharing and then go to question 3. So the next question we'd like to ask is, does your unit or your research group or company require use of Estimands in trial design? We've got various options here. So we've got yes, if it's mandatory to now use Estimands in your trial design, or no, might not be on your radars at all. We've also, you might be trialing it, but it's not yet required. So it might not yet be in your SOPs that you need to use Estimands, or you might just be thinking about it. And again, it might be not applicable if you actually don't work in a trials unit or a research group or company that work on trials. So we're just keen to get your experience here. I think probably got 15 more seconds on this one. Just give you 5 more seconds for any last responses to come through. Brilliant. So I'm now going to share the results of this poll with you. Okay, so we've got 9% who have said that yes, their place of work does require use of Estimands in trial design now. So that's from 12 people. But we've got no for 31%. Now it's quite encouraging to see actually we've got 23% who are trialing it, but it's not yet required by their unit. And that we've also got a 34% thinking about it. So I think this is quite encouraging to see. And then just 4% not applicable there. Brilliant. So I've just got one last question to ask you now. So the last question I'd like to ask is, do you think we should be reporting Estimands alongside trial results? And I'll just give you 20 more seconds to fill this one in. And this is the last of the Zoom poll questions of this presentation. So just a few more seconds and then I'm going to close this poll. Excellent. If I share the results with you now, so we can see 94% say yes and 6% are unsure. Encouragingly, nobody has said no here. Brilliant. So thank you for filling in those questions. It's just really nice to hear from all of us. And that brings me to the end of this slide. So I'll hand back to Victoria now.
Thank you very much, Susie. Again, more questions have come in for you during that. So I don't know if you, over the next half an hour, want to have a look at those, maybe respond. Well, some of them about questions about how we should be doing it, thinking about estimands from past trials. And part of it is, you know, is there anything for consult on that plans being updated? Do you know if there's any plans for consult or spirit to be updated in light of estimands?
Yeah, so I haven't spoken to them, but I think Prissy might be touching on that in her next presentation. Hopefully it's on their radar, because I think, yeah, that might be the only way we get them into publications. But I think, yeah, for past trials as well, even if they haven't been designed with estimands, there's nothing to stop us including the estimand in the publication and making it then clear what the results of what treatment effect we've done. We recently did that for a trial. We could only actually get the estimand in the supplementary material, but we were able to reference it in the main text so that it's there and accessible if anyone wants to look at it.
Fantastic. And Susie, just final question. How do you feel? Because you've got your results from your review that you've done, and yeah, I don't know how surprised you were by those results, given that we're only 2 years in. And also, how do you feel in having seen the poll today from people?
Yeah, so I wasn't too surprised on the results, because we obviously weren't expecting a lot of estimands to be used. It was really a baseline look to sort of really unravel, do we need the estimands? Because can we work out what's being estimated without them? And unfortunately, it was quite a high proportion. So I think that surprised me that it was higher than it was. And sorry, what was the second part of the question?
It was about how the poll. That's.
Oh yes, yeah. No, actually, I was quite pleased with those polls results. It's nice to see that we're all kind of supportive for reporting estimands and using them and thinking about it and trialing it, because I think, yeah, we are all learning about them all at the same rate.
Great, thank you. Thanks, Susie. You can have a break now and a rest. So it's my absolute pleasure to now introduce to you Chrissy Fletcher, who's from JSK. So Chrissy is a Vice President in Biostatistics. She was also a member of the ICH E9 Addendum Working Group, and she's part of an Estimand implementation working group, and that's what she's going to be talking to us about, some of the work that group has done today. So Chrissy, would you like to?
Great.
I'll hand over to you.
See my slides?
Yes, and yes, they're not on slide view, if you sort of mean. Then
they're
perfect. Thank you.
Yeah, so thank you for inviting me today, and I've really enjoyed the presentations this morning. I had the joy of being part of the ICH E9 working group. I was one of 6 industry representatives from both Europe, the US and Japan. So that's how ICH works. It's an international society. And following the sort of finalization of the ICH E9R1, I set up this FPIA and SBI implementation working group, knowing that there would be a massive gap from where we have been in designing and analysing clinical trials to embracing this new framework. So that was set up just as the guideline was being finalised. So I wanted to sort of say, with this new guideline, it is a new framework, and you've seen how it works this morning. But there are some new definitions. So what does a sensitivity analysis mean is different now. We need to make sure we embrace that going forward. E9R1 no longer really supports per protocol analyses. They have been biased. We have been excluding randomized patients. And that is no longer really where we should be when we're trying to estimate unbiased treatment effects. We've been calling analyses intention to treat when they're not intention to treat. So we have to sort of realize we've sort of gone down a path in the last 10, 15 years where we have actually become misaligned to E9. And that was what drove E9R1 to be put in place. And missing data, we've heard a lot about missing data. It is about where do patients' outcomes, where are they not able to be ascertained because of truly missing data, and not collecting data, then deciding you don't want to use it, set it to missing, and then call it missing data. So again, we're really trying to make sure we're clear on what is it we're trying to do. There's been a lot of discussion about the supplementary analyses and what does that really mean. So I'm glad that Susie, you covered that. But it is a journey, and you'll hear today that we are still on that journey. And for colleagues who are used to PICO, there is a lot of synergy with PICO and the Estimand framework, and hopefully you can see that them now beginning to connect. So again, it's disclaimer. I'm going to talk about this survey that I ran last year and what came out as key messages. I also want to share with you some key recommendations that the EIWG have written in a paper that became available online on Monday this week. Talk about a little bit more about what we are doing in our EIWG, an example being the Estimand Academy, and I'll end with some conclusions. So we did the survey. It started in Q2 last year. It went out as far as I could distribute it within FPIA, the industry and trade associations, but to the FSPI and European Statistics Organization, and we tried to disseminate as much as we could. Remembering, as you said this morning, estimands are not statistical. They relate back to the clinical trial objective. However, because we tied E9R1 to E9, it's a revision, first revision in 20 years to E9, which is the statistical principles of clinical trials, everybody has thought, oh, this is just a stats problem. And we are going to be living with that for many years to come. We did discuss at the time when the ICH E9 working group was kicked off, should we align this to E8, which is general considerations in clinical trials. And I wish we could have maybe tied it to both E8 and E9 to enable our non-statisticians to really embrace this new framework. But I will share with you some of the highlights of the survey. I am writing a publication of this, which will hopefully come out in the next month or so. And we asked for feedback on where have you used Estimands and the framework? Who's been involved? Have you interacted with the regulatory agencies? What has been your experience? But where could additional information be helpful? Has it added value? And where do you see some feedback on what you've experienced so far? And we did have a lot of sort of text comments as well given to us. Surprise, surprise, most people were statisticians. We did have some clinicians, some EPI, health economics people, regulatory affairs colleagues, and a lot of people had, were quite experienced in clinical trials or in the industry. So, at least over 10 years in most cases. Most of the experience had been in the later phase trials, so phase 2 and phase 3. That wasn't a surprise because the like E9 is covering all statistical trials. There is a focus on confirmatory trials, but all the principles are applicable to all types of trials, including interventional and non-interventional. And you can see that, yet the majority of the application has been randomized, but there has been, some, and this was a year ago now, some application in either single arm trials and non-interventional, but a small proportion at that point. We asked, where are you describing your estimands? That was a question this morning. ICH E9R1 does ask for estimands to be in the protocol. It's a requirement. It is not supposed to just be put in the statistical section because it aligns to, an estimand aligns to the objectives. So you can see here that people are beginning to include in the synopsis, in the objectives, in the stats section. Some people have introduced a new estimand section in their protocols. Because of trials ongoing, they've done it in an amendment. And clearly what is in the protocol often gets also transcribed into the analysis plan. And that's where the estimands and estimation is then described in much more detail. So a lot of participants who responded said they have either modified their existing protocol templates. Again, we have the Transcelerate template that's been around for a long time, and many companies will use that. And again, a lot of people had defined Estimands mainly for efficacy objectives, but Estimands can be applied to both efficacy objectives and safety objectives. Half the respondents who had engaged with the authorities said that that did result with agreement in Estimands. So the whole point of this addendum was really to try and ensure there was alignment at the start of a trial. We want to move away from regulators seeing clinical trial results in submissions and disagreeing with what has been estimated, and also disagreeing with the methods of estimation. So we're supposed to be now having these conversations at the start of our trial designs. And this is important here because until E9R1 was introduced, all we were able to do was actually follow intention to treat, because E9 just covers intention to treat principles. But as you've seen today, there are other different clinical questions where actually a treatment policy strategy might not be addressing the clinical question of interest. So we're now beginning to see regulators allow sponsors to use other strategies that are not treatment policy. But please don't misunderstand. There is still very much a need to address treatment policy strategies with regulatory agencies. That is still a primary interest. But E9R1 allows sponsors to think about other and more important treatment effects that, depending on the phase of development and what is, again, trying to be addressed by that clinical trial. So again, this survey last year, the respondents said that there's now more agreement on the Estimand, the treatment effects of interest, more agreement on the analysis methods, and beginning to see other types of clinical questions being addressed using different strategies other than treatment policy. And clearly the addendum came out finalized just before the COVID-19 pandemic hit. And I do think the addendum really helped us to manage through adapting our clinical trials in response to the pandemic. It was really timely for that. This is a busy slide, but let me walk you through. The green is the agree and the blue is strongly agree. So we asked about rating experiences. So from the left-hand side, do you understand the framework? Is it easy to implement? Are you satisfied with your estimands that were developed? Did it give you clarity on what you were estimating? Do you know when to define additional estimands? Did it help with your study design process? Did it enable you to design the study in a shorter time point? Do you feel that you have aligned your analysis methods now to the estimands of interest? Has it helped you understand how to interpret estimands when reporting trial results? And did it help to assess the impact of COVID-19? So again, this was sort of March, April last year. So we were, again, a year into the pandemic by that point. But I've highlighted in purple, whilst there are some areas where, yep, this has really sort of been understood, it hasn't been easy to implement. So I'm not surprised for the feedback this morning. It's a different way of thinking. It's a different mindset to think about the objectives first, what it is I'm thinking of estimating, and then using that to drive the methods. There was a mixed view whether it really did help the design process, again, primarily because non-statisticians have not really been engaged in understanding the framework as much as we wanted from the start. It hasn't led to a shorter time in designing the study, and that's probably because people are getting used to the framework and transitioning from what we were doing to what we should be doing. And there is some support that it has helped, but again, it was too early to say. Where could more information be helpful? Again, defining estimands came up, a lot of support for what strategy should I choose and how to really develop an estimand description. More information about defining sensitivity analyses and what is the role of supplementary analyses. and just my personal view is if any of the attributes of an Estimand are changing, that leads to a different Estimand, and that itself will have its own methods of analysis and will have its own sensitivity analysis. So I often refer to additional Estimands in the role of supplementary analyses are aligned to other analyses defined for pre-existing Estimands. And then again, we haven't really said much about reporting Estimands and interpreting, and I think that's where a focus area is now beginning to emerge, because we really haven't had much conversation yet about improving what we currently do in that space. Does it add value? Again, half respondents maybe said it did, whether it's helping to interpret the results, align on the objectives, and that's from a sponsor's point of view and also with our stakeholders. And remember, as we've said this morning, stakeholders are a number of people: the patient, the regulator, industry, HTA, other clinicians and viewers who really want to know what does a new drug do and how does it work. There's different views, and we need to think of all those different stakeholders. There are concerns that does the framework increase how we do trial design? Does it lead to complexity? Does it enable us now to have multiple different analysis results if we've got a primary Estimand, an additional Estimand, we're changing different intercurrent events, and these are all valid concerns. So there is as we get more experience of applying the framework and understanding how we align, as Susie said, from the top to the bottom, and other speakers have said. But it's a journey we're on, and I think people are still feeling uncomfortable about it, and they will need more support to sort of walk through and get used to it. So really our conclusions were that it is a journey, it's going to take time. Training continues to be an area of focus, and really when you can share case studies like today, it really does help to crystallize our Estimands clear, looking at publications from the past. We hoped at the time things were clear, but when you go back, we realize maybe they weren't clear. So the Estimand framework is leading to more alignment in the design phase between sponsors and regulators on what are the trial objectives and then what are the treatment effects of interest. But we do need to think about how we can further help with implementation. So what is additional information that would be helpful? And the concerns remain if the framework's increasing the complexity. There was a lot of concern about, do we have to increase our sample size? Because if we do want a true intention to treat principle, then treatment policy may be attenuating our treatment effects. We may not have realized that we were ignoring data before, and now we want to follow all patients. So again, we just need to sort of work through some of these issues as we get more experience. And yep, the EIWG and these members here came together to say, well, let's learn about what we've done in the last 2 years. So we sort of marked 2 years of new thinking, and we call it an Estimand journey. So I hope you enjoy reading this paper. It covers a lot of where we were when the addendum came out, what we've learned in the last 2 years. We've talked a lot about both describing Estimands, but also the estimation issues, which I know you're covering as part of this workshop. And we also recognise there's more to do about reporting Estimands. And we came up with some recommendations. We've come up with this. This is the typical approach of the implementation process. You have to start with awareness and education. So like your workshop today and tomorrow, what is an Estimand? Provide some motivational presentations, enable materials, training materials to be released to your trial teams, developing subject matter experts who can be called upon. You have to promote the Estimand thinking process. It's a new way of thinking. Think about how you might want to write Estimands in your protocol templates. There's no right or wrong way. And the E9 guideline does not tell you how to write it. It's giving you the principles for things to consider. But what might be the implications when you're thinking about once you've defined your estimands to the methods of estimation? And what might be the implications for your reporting and transparency of results? So we do a lot of reporting our trial results as per our expectations in our transparency efforts, in publications, in slide decks. That really hasn't been, I think, resolved yet. And we will need to continue the journey to make sure that we do realise the potential of the framework. So think about how you can share case studies, how often, the different types of different settings where these can be implemented. And think about, all the different stakeholders that you need to be involved. So your medical writing, if you have different groups for in your different organisations, bringing patient views to the table. There is the HTA aspects. There is the other medical considerations. So, we need to embrace all of these and adapt ourselves as we go forward. And we had 8 recommendations in our paper. So we think the Estimand thinking process is a tool to help think through trial objectives to the Estimands, the treatment effects. That does lead into the choice of trial design, how we then conduct and collect data and follow patients into the planned analysis methods. We wholeheartedly agree with the feelings this morning about that the terminology has been a big barrier. So where possible, use non-technical language. This will help other stakeholders that you're working with in your clinical research teams to understand what it is. So we are, again, like baking a cake, other recipes, other ways to convey what is it's coming together and how. And that's really made a difference. There is implications to our trial teams in terms of how studies are going to be conducted. Investigators need to be aware, patients need to be aware that we want certain data to be collected in order to stay aligned to our planned estimands. So we need to educate all the stakeholders about, for example, when patients are signing informed consent, if we need to get a week 52 observation from you, please stay in the study until week 52. Whether you stay on treatment, do not withdraw from the study if you're going to discontinue treatment, if we're taking a treatment policy strategy. And we are moving away from analysis sets. That's been, I think, one of the mistakes we made in ICH-E9 is we were thinking about what are the patients to be included, and that's where the analysis populations came sort of to the forefront. But intention to treat principles were always about what are the patients, but what follow-up is required. And every Estimand will have its own grid of data, its set of data that will be used for estimation, because every Estimand might embrace an intercurrent event using a different strategy. So we really need to think about that set of data for each Estimand, which is going to then be the basis for our methods. Sharing case studies, really, really helpful. Start to end, what's the clinical disease setting? What are the clinical questions that are important? What then is the primary clinical question leading to a primary Estimand? But what might be some additional Estimands that are aligned to the primary objective? How do we then, report this, both in clinical study reports and publications, in clinical trial registries? We recommend offering drop-in consultation sessions. So if you do have some groups, some SMEs, some experts who begin to really adopt the framework, allow other teams to contact those colleagues and help to embrace the framework. Really important if you're in a regulatory setting where your trial is going to go for be part of a submission, is to get feedback from the regulatory agencies and other key stakeholders, for example, our HTA agencies, on our proposed estimands, our proposed estimation strategies, and giving a rationale. Why have we chosen that estimand? Why does it align to the clinical trial objective? That really helps all our stakeholders to understand the choices we've made. And we want to sort of share the feedback across different teams. Again, we are learning as we go through. And finally, provide trainings, host seminars as diverse as possible, reaching out to different stakeholders, promoting discussions, what we're learning. It's fair to say we've done a lot of that in the statistics communities. We do need to do more in the clinical communities, but other stakeholder groups as well. I think that's where we are as part of our journey now. And the EIWG is very active, and I'm pleased to say that Ian and Brennan recently joined our team, which is fantastic. We ran 3 seminars to date, and they're all linked. So again, and these are available publicly. So we talked again about the Pioneer. There's one in oncology, and we talked about the ethos study, and that was getting into sort of the publication side of medical journals. But we've got other ones being planned, the impact of Estimand, a case study in neuroscience, and Estimand's in early development. And so every year now we're planning to really sort of share some of the broader applications of Estimand's. But we're also doing a lot of other things. So we had a team looking at how do you incorporate Estimand into clinical trial protocols. There is a publication under review in the Trials Journal. We've also been looking at early phase studies, the implication of Estimand in non-inferiority trials, Estimand in non-interventional studies, how best to report and communicate Estimand. We've been getting into our estimation methods and doing some simulations, especially with the treatment policy strategies and how much on and off treatment you have. And we're trying to develop a much better sort of EIWG central resource for all our materials that we've developed to date. That has led us to developing publications, white papers. We've been looking at publications that others are publishing and having discussions about those. We've been involved in the ICH M11 team, which is developing a new ICH protocol template. That will be coming out for consultation this summer. So that's going to drive, again, maybe a new standard for protocol writing. And we're looking forward to the UNETA methodology guidelines that are starting to roll out next week. And this is going to form the basis of the processes and methodologies for the new EU HTA regulation that came into effect last year. We have been discussing with NIH how to incorporate Estimand in ct.gov. We were able to get connected to some NIH colleagues recently, and I think one of the first questions was, what is an Estimand? So we have some work to do there, and we've shared some of our materials, but clearly we've been reporting our trial designs in ct.gov for many, many years, but we've been fitting a sort of round pin into a square hole now for some time. It should be, I think we need to sort of talk about how better to describe our intercurrent events, which again are not easy to do in ct.gov. And we are in collaboration with authors of Consort and Spirit for how Estimands are being incorporated. From a Consort point of view, one of the lead authors feels that there is already some sort of connection with our Estimand framework already in the guidance, but we were asked from the EIWG point of view to provide some recommendations on what else could be made more transparent about Estimands in the current guidance. So we're currently looking into that as a sub-team. So in conclusion, the Estimand framework has really shifted focus away from ITT analysis to clearly defining treatment effects of interest, which are driven by your clinical objectives. This requires cross-functional input and alignment. It's not a purely statistical analysis problem to solve. There's still more work to do there to really embrace this across all our broad stakeholder communities. A new definition of sensitivity analysis ensures that each analysis and each sensitivity analysis is now aligned to that Estimand. So we shouldn't be mixing and matching. Case studies, training and awareness sessions have really helped to illustrate concepts, but the language and new terminology has been challenging. So whatever tactics and strategies you can to really help to educate is really what we need to do. Most attention to date has been on defining estimands. We now need to think more about the estimation and reporting. So I think there'll be a lot more now published in that space going forward. And we are on a journey, it continues, and there is more work to do, as sort of illustrated today, to support the broader implementation, to keep learning from each other, and to really make sure that we're clear in our clinical trial design what it is we're trying to address in our trials, the estimands of interest, and all our methods are aligned and can be very easily understood. And that's me finished. So I'm happy to take some questions.
Thank you so much, Chrissy. Do you want to stop sharing your screen? And we have got some questions. We've also run out of time, but we'll take a couple of questions. I've been looking through them. Actually, because we're on this journey. So my question really to you is, how fast do you think this journey should be?
Well, I think we can make it as fast as we want, but I think we've seen, even in the E9 working group, it took us a while to get our heads around what we're trying to do. I think it's worth spending the time on educating and awareness. So I personally think if you can get that in place but do that in a cross stakeholder way, that time aligning to that will give you then the opportunity then to embrace the implementation, maybe speed up there. But if you go too fast and you don't have that understanding, I think you might be creating more problems down the line. So I would advocate for that.
Because I think that this is something that Francesca raised, of saying, look, we're trying hard to implement the Estimand framework, but actually it feels like there's this lack of training. And like you also commented about, we've got to move away from defining the Estimand to actually, for doing it. Do you not have any sense, is there no ambition for, you've got a number of years that you would like to change practice within, or is this,
we have. Yeah, so I know from the survey results today, maybe there's not been a lot of experience here in non-industry sponsored trials, but I think it does need to be embraced. It's been around for 2 years, so at the end of the day, it is in place. We were already implementing it before 2019. So I wrote my first Estimand in a clinical trial protocol in 2015. Which is then when the FDA was starting to ask for estimands. So we've had many, many more years, I think, of some implementation. So I think thanks for the challenge. I think we do need to really embrace this more broadly. And the best way to accelerate it is through case studies. So I would maybe set goals within your organization. Where are you now? Or maybe can you try to embrace it across an X percentage of your portfolio, within a year's time?
No, I think, and thank you so much for your fantastic talk, because actually where we're trying to move and make a change, actually hearing about other people's experiences is quite helpful to see how everybody else is finding it. So a final sort of point or question, in one of your recommendations, you've got about, we need to be getting the stakeholders together. Now, as statisticians, this is the kind of problem we love. We're like, we can spend all our time thinking about this and like it. How do we engage those other stakeholders? You've taught, even from your survey, your clinical response from clinicians is really low, let alone patients and who else. And I think this is things Min also talks about. Terminology is a massive issue. So I just wonder if you've got any comments about how do we do this?
I think statisticians can take a leading role by bringing people together. So we have to just be proactive and get people around the table. I know companies work and organisations work in different ways. But what we're trying to do is make sure that we want to really ask our clinicians to also step up and do this jointly. Because if statisticians keep driving it, people think it's a stats issue, and it's not a stats issue. So what we've done is we've tried to set up working groups which are co-led by clinical and statistical leaders. So we're seeing, and it gets the top support from your clinical research, like head of clinical research. They need to buy into this and say, I'm committed, I support this, I understand what we need to do. So you need that top level support, but co-leadership from clinical and stats. That will just help to really drive home across all the stakeholders.
Fantastic. Yeah, we need to hand the baton on a bit. Yeah, fabulous. Right. So I think we've overrun a little bit. Thank you everybody for the talks today. Thank you so much to Susie Crowe, who's done all the organising, planning, plotting,